Hello everyone, today we will discuss about portal hypertension and ascites. So what is portal hypertension? There is increased pressure in portal veins. Portal venous pressure is increased because of other causes like, let's draw a lever. Alright, this is our lever. Now, that's portal artery. Now, this is portal vein. Now, first is pre-hepatic. These are all the causes which is leading to portal hypertension. So, pre-hepatic, intrinsic, and inferior vena cava coming from. Alright, so this is hepatic vein which is leading to liver. So, this is post-hepatic. Now we will see what are the pre-hepatic causes is portal vein thrombosis. Now intrinsic is all the things which is happening inside the liver is cirrhosis. Alright, so post-hepatic is, that's a major cause of portal hypertension, most common worldwide. Now, what is post-hepatic outside the liver? So, related to hepatic vein thrombosis, right heart failure, hepatic vein thrombosis, anything happening here, or right heart failure, anything outside the liver, post-hepatic. So these are all the causes which is leading to portal hypertension, increasing the venous pressure, portal venous pressure. So what actually happening in portal venous pressure? Portal venous pressure increase, which means transudate. By physiology, we know that it is increase in hydrostatic pressure. And decrease in colloid, or you just can write oncotic pressure. This is classically for USMLE exam purpose. This is classic for transudate causes. I mean, what's happening in transudate, we'll see ascitic fluid, and we will see what is SAG is. So we're gonna just review shortly. So transudate means, this is the physiology behind it, that there is an increased hydrostatic pressure and decreased oncotic pressure. And if you talk about exudate, it means increase in capillary permeability. Means all the inflammatory condition, malignancy, infection, where we have increased permeability, capillary permeability. Just clean it
And that transudate and exudate is, you're describing the ascitic fluid, right?
Yes, we are talking about ascitic fluid, exactly.
Right.
So now I will talk about SAG. Now it will be more clear why we mentioned transudate versus exudate related to the specific condition. Like, now what is SAG? SAG is
serum albumin ascitic gradient.
Yes, serum albumin ascitic gradient. Now, we will write it in a fraction, what is actually a subtraction of serum albumin minus ascitic albumin.
Great.
Ascitic fluid albumin.
Sure.
Now, we should know first, before going in detail, we should know the level of what is how we see in the questions and what is the main thing. But as soon as you know that if the SAL gradient, I mean, if a serum albumin subtraction with ascitic fluid, if the gradient is greater than 1.1 gram per dl or less than 1.1 gram per dl. So that are the causes. So first we'll talk about portal hypertension related. So there will be more gradient. Now what are the causes? Portal hypertension related. We'll talk about portal, where the gradient will be increased. Portal hypertension related to this is cirrhosis, where the gradient will increase. Now CHF, constrictive pericarditis, you can just constrictive pericarditis. So we are just focusing on the high yield. Constrictive pericarditis, and here happening is, this is a transudate picture. We have increased hydrostatic pressure, and decrease oncotic pressure. So,
and CHF will also fall under here?
CHF also falls under here, but most likely it is everything is happening which is leading to, those are the causes which is leading to increased portal hypertension things.
Right.
So these are the things, is hepatic vein thrombosis, yeah, CHF, congestive heart failure, all these things happens here because here we have a transudate picture. That's why the gradient is increased and there is a decrease on oncotic pressure, and we have a hypoalbuminemia. That's why there is a decrease on oncotic pressure. Hypoalbuminemia, and the gradient is increased. So the hydrostatic pressure increase, the portal hypertension increase. So these are the causes where you have to find out where the serum albumin ascitic fluid gradient will increase greater than 1.1. So these are transudate causes leading to increased gradient.
So basically, because it's a portal hypertension picture, we are saying that the SOG gradient is indicative that, in this case specifically, greater than 1.1 means that the portal hypertension, it's elevated pressure greater than 11. Therefore, then you had written on the left beautifully that there's increased hydrostatic pressure, which is the portal hypertension, which then in effect decreases the oncotic pressure, which is the protein, leading to low albumin. And that's how this whole thing kind of comes together.
Exactly.
And everything is basically right side of the body, like the CHF, congestive heart failure, constrictive pericarditis, hepatic vein, everything is in that pathway.
Yes, exactly.
Excellent.
So if you talk about less than 1.1, then you are thinking about exudate, right? So there won't be any portal hypertension. There must be different causes. So if we talk about less than, if SAG is less than 1.1, then the gradient is low, which is less than 1.1. So think about exudate. So the gradient we are coming from ascitic fluid, and we are checking, and we know that it's exudate. So exudate is always inflammatory condition, malignancy, infections. So infection are the main culprit. Infections, malignancy, and one more thing is
good old nephrotic syndrome.
Nephrotic syndrome. Wonderful. Syndrome. Alright, so here we have infection, but except SBP.
Right, except SVP. Great point.
So what's happening here is capillary permeability is increased. So that's why there is a leakage, or we are losing a lot of protein here, as we know, nephrotic syndrome. And that's what's happening here. We are losing protein, and that's exudate causes of leading to decreased gradient, serum albumin versus subtraction of ascitic fluid. So that's why the level is less than 1.1. So if you are doing question and leading, if you think that it's hard to know, just go with the picture, go with the history. So because these are all causes of portal hypertension, and what's happening other than that is these are exudate causes, which has a less than 1.1 gram per dl gradient. So go with the range less than 1.1, all these causes. Greater than 1.1 is a portal hypertension related to all other things, hepatic vein thrombosis, constrictive pericarditis. So those are the commonly tested questions they ask.
Got it. So SOG basically helps us figure out what's the etiology of this ascitic fluid.
Exactly. Yeah.
Is it portal hypertension and right heart kind of picture, or is it more of a malignancy, inflammation, infection?
So this is exactly the same thing when you do the, here we are doing a paracentesis to make sure what is the gradient for ascitic fluid, but for pleural effusion we do thoracentesis. So here the main reason we are looking for gradient is to know what is exactly the cause by going with the level of 1.1 gram to make sure it is a portal hypertension causes. If it is less than 1.1, as we said already, infection related, exudate versus transudate. This is transudate. Excellent. And this is exudate.
Yeah.
How would we know? We are actually doing here is paracentesis. We are checking the ascitic fluid,
right,
to make sure what's the gradient, and then we are checking for SAG, and when the level is like this, then I should explain it before writing it down, but that's how we are doing paracentesis. We are checking for the gradient, and then if it is greater than 1.1, transudate causes. If it is less than 1.1, that's a range we are looking for, which is exudate causes. Now the same thing we are doing for pleural effusion. If we are talking about pleural cavity and pleural effusion is going on, so we follow the light criteria there. So this is, now we write in black. So this is for same things. We will just also write the causes. So see, light criteria we are using for why we are using doing this light criteria. This is for after doing thoracentesis. Thoracentesis, we are removing the pleural fluid and we are making sure that we are following this light criteria. By checking pleural protein versus serum. So the light criteria has three things: pleural protein, LDH, and third is LDH level greater or less than 2/3 of normal level of serum LDH. So this is a pleural comes first, always pleural divided by, okay, pleural protein first, serum protein. Here is serum LDH, and LDH is less than or equal to 2/3 of upper limit, less than or equal to 2/3 of limit, or greater or equal to 2/3 of normal level, normal level of less than or equal to 2/3 of normal level of serum LDH. So like we just need two things. Just remember if this is hard, just follow these two. We are enough. But the range is greater than 0.5, greater than point. Yeah, if you talk about greater, greater than 0.6, and that's 2/3 we can do the ratio. So, but the thing is, I will write it why we are doing thoracentesis, to make sure what are the main causes. So let me just tell you exactly. We are following the same pattern. Why we are saying that why we are using light criteria, and to make sure that it's exudate versus transudate.
Cool. So pleural fluid is a lot like ascitic fluid.
Yes, it's the same way that the one I'm trying to mention here is like a, let's follow that transudate, same physiology.
Right.
Date versus exudate.
And here, this lights criteria helps us with the etiology.
Yes, light criteria is helping. So what, as we said, that light criteria here is first one is 0.5. Remember 5, 6.
Nice.
And the last one is 2/3. So I will just go with 1 and 2. We just need 2 criteria to just make sure whether this is exudate versus transudate. So greater than 0.5, greater than 0.6. Here is here is less than 0.6. Now if you if you have these 2 things less than, so what's happening? The same physiology: increase hydrostatic pressure, decrease oncotic pressure, and here is permeability. So same causes. The reason we mentioned this here, that same thing is happening here also, but the different range and different composition. So what are the causes here? Exudate, same infections.
Great.
All like TB, fungal, anything. Malignancy.
We had all the same etiologies. Excellent.
All have same etiology. Same thing. But transudate, what's happening here is same. CHF. Cirrhosis.
Yeah.
All has like same, like what was happening in the ascitic fluid, same happening here. But we have to just rule out by doing paracentesis in the case of ascitic fluid, and we do thoracentesis to check pleural effusion, whether it's exudative or transudative.
Great. And for lights criteria, we need 2 out of those 3?
Yes, 2 out of these 3.
Got it. That makes it nice and easy that we kind of follow that same physiology, and it applies to the ascitic fluid, or because both are fluid.
Yeah. So what are the indication for paracentesis? How often we have to do? If we find out the patient is having a new onset of ascites, then you have to do. So indicated, after you once done it and the patient comes back with a new onset of ascites, you have to do it, because you have to take it out. Second is patient having abdominal pain, tenderness, you can say that, tenderness, having a fever. So these are the indication to do paracentesis right away. So why we are trying to make sure the patient is not having a spontaneous bacterial peritonitis, SBP, because if the patient is having a fever, there is something infection going on. So we have to do paracentesis. We have to take the fluid out, ascitic fluid, and make sure that patient is not having spontaneous bacterial peritonitis. So how would we know that the patient will have a peritonitis? There is a range of neutrophils in the ascitic fluid. So what is that range? That range is neutrophils in the ascitic fluid. Ascitic fluid. Neutrophils greater than 250. That's a range. If that is there, we have a diagnosis, SBP. How to treat SBP? Spontaneous bacterial peritonitis, with antibiotics.
Right. Okay. People often confuse the prophylaxis versus the treatment.
Yes. So antibiotic is ceftriaxone, or you have a choice, cefotaxime.
Nice.
Cefotaxime. Now for the exam, we should know that they love to ask about prophylaxis in order to prevent SDP with fluoroquinolones, especially norfloxacin.
That's a great point.
Yeah. Then also you can add later on TMP, SMX, Bacterial. SMX.
Excellent.
Okay, now the last thing is that if we need to know the color of ascitic fluid, let me just remove this. So if the color is blood, I mean if the color is bloody. If the color is bloody, what could be the causes?
Trauma?
Yes. If it is bloody, alright, it's trauma. Could be TB.
Yeah, TB.
So these are the most likely.
And then maybe even cancer, I guess? Malignancy?
Yeah. So
yeah, I think those colors. Don't
yes.
worry, yeah. I'll get you, let me see if I can get you a red.
Alright, so if we have milky color, then we know this. It must be chylothorax.
Yeah.
Not thorax, chylus.
Right, chylus.
Chylus, sorry. Now, it could be pancreatitis.
Yes.
Pancreatitis leading to ascites. Color is milky. So if we have turbid, it's infection likely. Turbid.
Yes.
Turbid.
Infection.
Could be infection. And if we have straw-like color, could be benign. Straw color, benign. Cause, or just remember for exam purposes, like we likely tested is these two, and then blood. So last but not the least is, that's a simple way to remember what is the total protein in ascitic fluid. So we have to just follow the level of the exam. So the total protein in ascitic fluid is, the level they testing for the exam purposes, if it is greater than 2.5 gram per dl, it means high protein. So think about all the causes of CHF, just right. We're talking about ascitic protein. Total protein. It has nothing to do with gradient. Gradient was another thing. This is total protein. If protein is greater than 2.5, it means all other things, CHF. So if you just exclude, bear with me for a second. If you just exclude less than 2.5, it means protein is losing. All the condition where we are losing protein is cirrhosis and nephrotic. If you just know these two, nephrotic.
Then everything else falls in the other category.
Exactly, everyone falls in other category, like whether infection, TB, fungal,
constrictive pericarditis. Yeah, and you had even told us, I think, Budd-Chiari syndrome.
Oh, wonderful. Budd-Chiari, hepatic vein thrombosis.
Yes, that's a great trick that you did there.
Yeah. So pretty much enough. Do not confuse with gradient. Gradient has its own value, and total protein. If they're asking about ascitic fluid, total protein must pay attention in the question. If it is greater than 2.5, of course, these are the causes, and go with the history. But if it is less, more protein is losing here. These are two causes where we are losing protein. albuminemia, of course nephrotic syndrome, you're losing a lot of ton amount of protein in the urine. So this is the level. I think I'll just go again with the
yeah, maybe tell them once more.
Yes, the gradient is, there's a difference between serum albumin minus ascitic albumin level. So that's a gradient, ascitic fluid albumin. So
and basically it's just a subtraction.
It's just a subtraction. And that's the level we are following it when we have transudate causes. It should be greater than 1.1, where we have portal hypertension.
Yes, that's
all this thing. But other than that, if exudate cause, the level will be less than 1.1. Infection, malignancy.